Hello there, my name is Michael Mazzei. Today I'm going to be talking about trauma recidivism and a conceptual model surrounding that. Now, when one thinks of trauma, I think that many people imagine it as an isolated incident in which someone is injured, is taken to the hospital where they either live or die, and if they live, they're discharged, and that's sort of the end of it. Fortunately, realistically, that's not the case. In approximately 7% of trauma patients, those who have suffered a trauma will have had a history of a repeat trauma. They're referred to as recidivists. Now, when we say trauma, we mean gunshots, stab wounds, assault, violent trauma, as well as things like motor vehicle crashes, falls from standing, concussions, etc. Typically, though, recidivism refers to victims of violent injury. Now, after a patient survives their first trauma, they're twice as likely to die from trauma in the future. Within 5 years, 20% of those suffering major trauma will be dead, oftentimes because it's very hard to extricate oneself from the high risk of trauma situation that caused the initial trauma. Certainly, it is clear that we as public health servants should be instituting programs that define what the factors are that cause trauma and then reduce the risk of trauma recidivism in the future. Now, the average trauma recidivist costs about $2.5 to $4 million, mostly in loss of productivity. Hospitals who have instituted programs directed at preventing recidivism have consistently shown financial gains as a result of these programs. As far as the populations that are affected by recidivism, trauma recidivism, it's typically disadvantaged populations such as African Americans, especially males, those suffering from addiction, victims of domestic abuse, and then elderly individuals who are at risk of multiple falls, although frankly that's not really the population we're discussing here. Now, there have been a number of different papers looking at trauma recidivism using the various models that we have gone over in class. One particular model is the theory of planned behavior as it applies to violent men performing abusive behaviors. This particular paper used the theory of planned behavior, which, as you will remember, states that behaviors are defined by the intentions to carry out those behaviors, which in turn are influenced by three factors: subjective norms, namely social pressure to perform or not perform behavior, individual attitudes towards the behavior based on what the likely outcomes are perceived to be, and then behavioral control, which is sort of a self-efficacy variable, the perceived ease or difficulty in performing a behavior. Now, this is taken from the paper with some of my own addition. The paper states that it is important to understand the processes that underlie recidivism and then develop a general model for evaluating the factors that could be intervened upon in a public health setting to reduce the risk of trauma recidivism. For example, for subjective norms, the idea was that perhaps a sort of by influencing community anti-violence advocacy groups, there would be a decreased social norm or a more negative perception of violence that would influence the intentions of the behavior. Regarding attitudes toward behavior, by causing criminal justice sanctions on violent offenders, they would be less likely to perceive of trauma as having a positive outcome, or violence as having a positive outcome. Then from the perceived behavioral control, things like anger management or increasing the ability of potential violent offenders to remain nonviolent, and therefore decreasing their risk of trauma recidivism. That was just sort of some of the factors that they discussed in the paper. Now, the paper, of course, has strengths and weaknesses, or the model itself. The model is simple and fairly effective in dictating sort of the interplay between social and personal forces in violent decision-making behavior. I also think that as opposed to something like the theory of reasoned action that doesn't really have a behavioral control aspect. I think that the theory of planned behavior nicely captures the fact that oftentimes those who are in a traumatic situation do not have the ability to remove themselves from the situation. They don't have a lot of control due to gangs, drugs, peer pressure, etc. I also think that there have been a number of studies looking at theory of planned behavior, and it's fairly predictive. Now, the weaknesses are that in this case, the model that they built was only weakly predictive. Additionally, I think number one, I think that this model has a lot in as opposed to a cognitive theory. It's more of a behavioral theory, and I think that there's a lot of sort of interplay and similarity between the two. I also think trauma itself is it can be a random event or a crime of passion, and so looking at under the guise of a planned behavior or a reasoned action, I think is a little bit unrealistic. Oftentimes people go very much against their reasoned behaviors or the behaviors that they've thought out. They go against their better judgment in getting involved in trauma situations. So I feel like that might be a weakness. Also, I think that the model itself has this intention to commit violent behavior or intention to be a trauma recidivist, and I don't think that is ever possible. No one is either going to admit they want to cause traumatic injuries to anybody, and of course nobody intends to be a traumatically injured patient. So I think that this kind of weakens the model. Another model that is maybe a little bit more applicable is the social learning model that's used in this particular paper shown here. And the social learning theory is the concept that learning is not just behavioral, it's a cognitive process that takes place in a social context. Behaviors are learned by observing other people's behaviors, attitudes, and the outcomes of those behaviors. This is the concept of reciprocal determination, or rather, the concept of reciprocal determinism states that the learner is not necessarily a passive recipient of information, but there's an interplay between the factors that influence learning and the learnee. They all influence one another. Now, the three factors that are thought to influence learning in Bender's model of social learning theory is A, cognitive factors such as knowledge, attitudes, and expectations towards traumatic injury. Behavioral factors, the skills and the practice that one performs, as well as self-efficacy, which we've sort of previously described. And then environmental factors, the social and norms and the environment and the various influences from an external source on the subject. Now, this is not taken from the paper, but the lists on the points of each part of the triangle are indeed taken from the paper. Now, the paper identifies that it's important to determine which risk factors for aggressive and violent behavior are most correlated, are most predictive, rather. And then, based on the understanding that these are correlated with high recidivism rates. Now, here, for example, from a cognitive standpoint, it's noted in the paper that social and emotional deficits are highly correlated with high-risk behaviors likely to cause trauma recidivism, as well as beliefs that aggression is sometimes a good thing are also quite predictive. From a behavioral standpoint, things like criminal conviction, aggressive or antisocial behavior, peer delinquency, firearm ownership, and drug use, these are all behavioral factors that make it more likely that someone will become a trauma recidivist. And then environmental factors, caregiver violence, or that is living in an area where a caregiver is likely to be abusive, witnessing violence regularly, and as well as things like poverty, homelessness, unemployment. These all increase the likelihood that someone will engage in high-risk behavior and therefore be at risk for trauma recidivism. Now, there are some strengths to this paper, this theory as well. I think it also accurately captures the interplay between social and behavioral factors. It also, I think, is more, the cognitive aspect is more sort of adequate for assessing the emotionally charged environment of trauma. It's also worth noting that Bandura's original work dealt with violent actions, the Bobo doll experiment. And so I think that this model is particularly well built for this type of research. The weaknesses are, I think it's more complex of a model, and therefore it might be harder to study due to the interplay of variables in this sort of reciprocal determinism manner. I also think that recidivists by nature are have committed a action or a behavior with a negative outcome and did not learn from it. So in both these cases, really, I wonder if the rationality that these models sort of imply is sort of false. So my own model that I developed, it is sort of it definitely pulls heavily from both these models. The idea of my model is that traumatic injury is dictated by high-risk trauma behavior. That is, someone is in a situation, a risky situation, and the context and the time is right, they will sustain a traumatic injury. And so it's traumatic injury is indirectly affected by factors that make it more likely that someone will engage in high risk of trauma behavior. I believe that there are external factors and internal factors, and I've highlighted some of them here. They have sort of various variables. At the risk of being cute, I kind of gave them an A, B, C, D, E, F mnemonic. But the interesting thing I think about this model is that when a traumatic injury occurs, there are consequences of that traumatic injury that feed into the external barriers and internal barriers and make it more likely that the patient or the subject will continue to participate in high risk of trauma behavior. This explains the sort of cycle of trauma recidivism. Now, some of the barriers internally that cause someone to have problems avoiding trauma are things like addiction. And remember, when someone is traumatically injured, they're given pain medications. So a traumatic injury can fuel addiction in the future. This is that cyclical thing I was talking about in the model. Also, just naming a few of them. You can read these on yourself. Like criminality, right? If you're injured, traumatically injured, there's a high risk that it was because you were doing something illegal. And now you're going to have a criminal record. It'll be harder for you to get a job. You'll be forced to continue to participate in illegal modes of making income, and that will, of course, make you more likely to sustain violent injury. And then I listed here, or like injury is a good example, or disability. If you have chronic pain because of trauma, you won't be able to work certain jobs, and you'll need to pursue, potentially, illegal means of making money, causing a higher risk of traumatic injury. And then fear extremes I have here. That's the idea that traumatically injured patients can become either paranoid or feel invulnerable, both sort of causing future risky behavior. External factors, I think, are also, I'll name a few, like, lost school time, for example, can force people down more dangerous roads to make money. Peer behavior, there's an increased likelihood of hanging out with people with similar life experiences, and therefore you may sort of propagate this dangerous environment. The environment itself, people who sustain traumatic injury are less likely to be able to afford leaving the pervasively violent areas that they live in, and therefore, that is propagated. And then something like familial support, maybe the drying up of familial support. I'll simply end by saying that this is a major public health issue. I really appreciate you guys listening to me and letting me talk a little bit about it, and I very hope you much enjoyed the model. Thank you very much for your attention.